Hello, everyone, and welcome back to ImmunoLogic, the podcast where we take the cutting edge of immunology and stitch it together with clinical insight and just enough humor to keep the neurons firing, hopefully. As always, Joe Fraietta, your resident immuno-obsessive host. And today is a special bonus episode because we're doing something a little different, sort of a year-end recap of ImmunoLogic and also what we feel are the leaps in the field this year. So it'll be an interesting and more, I would say, Janna, right, extemporaneous episode. Our streams of consciousness here.
Definitely.
So how should we start? What should we talk about? What do you think? I don't know. There's so many things. It's endless. All right, let me start with a theme. Let's try this. Less brute force, and I'm asking the oncologist here. More biological intent. That's the scientist here. So when I look back at our episodes and just what's sort of evolving in the field, one theme for me keeps resurfacing that we're moving away from brute force oncology and more toward biologically intentional therapy, at least for some indications. You have to give me a little bit of latitude here. And what I mean by this is not what just kills the tumor, but what builds durable control. And honestly, that's, been the ImmunoLogic mission. I think what we're trying to do from day one, bridging the science with, how it actually lands in clinics and in trials. So as a practicing oncologist, I'll start with you and then you can turn the tables on me. Do you think that's accurate or am I totally off base?
I think it's absolutely accurate and particularly in lymphoma. I think I find lymphoma a particularly interesting disease because it's a disease of the immune system. And so our, conventional treatments for it generally hurt the immune system,
Yeah.
And while now our second line and later therapies rely on immune health to be effective. It's this kind of interesting little paradox that we have that I think that's been the impetus for a lot of ongoing work to decrease the amount of, for example, conventional chemotherapy that's used in early lines of treatment in the disease. I'm thinking, for example, of the bovine regimen for mantle cell lymphoma, or many of our approaches for indolent lymphomas, certainly.
What is that regimen? I'm sorry, foreign term to me.
Yeah, bovine. It's three medicines: obinutuzumab, venetoclax, and acalabrutinib or zanubrutinib. Sorry, zanubrutinib. I was trying to remember what the
it's
Brukinza is the B. I think it's
more than I wanted to know.
We don't use trade names on this podcast.
Oh yeah. Good point.
So it's a BTK inhibitor, venetoclax, and a CD20 monoclonal antibody.
Yeah, got it. So you mentioned a buzzword for me, which is immune health, and there's a huge initiative here at Penn, led by John Weary and Bob Vonderheide, and also at Stanford by Mark Davis, and other places. And I think it feeds into what we're talking about now. Like, can we be more deliberate as part of the equation? For when you're prescribing these things or thinking about, this regimen versus that, really an immune health score. And we could talk for probably days about what that should be.
Yeah.
But
and it's certainly on our mind as we're sequencing therapies. Bendamustine is almost a 4-letter word in the Penn lymphoma department.
Right. But how much of that could I ask you from a practical standpoint? Because I've always wondered, and I've heard of, we're doing it. I'll take a step back with like targeted sequencing of a tumor. But there are certain institutions, I think, who do it a lot more comprehensively, probably than we do. But how much of that information is actually exquisitely tailoring the treatment regimen, or is it just sort of good information to have?
I think maybe we're conflating two things. So I said,
tell me.
I said sequencing therapies, as in which therapy
sequencing?
Do you do?
Yes.
Yeah, one, then the next, and the next, and I think you're asking me about next generation sequencing.
Yeah. Okay,
Um,
well, let's talk about that
let's talk
now.
about next generation sequencing instead.
So, next generation sequencing, I'll be very specific. Like, how much does that, having that comprehensive profile, right, of what's mutated, and most of it, when I've seen these reports, not that I'm using them in any diagnostic way or anything like that, but it's you see a lot of variants of uncertain or unknown significance, and it's like you have all this information, it's incredible, but what are we actually doing with it? And I think that's step one before we probably will be implementing immune health scores, right?
Yeah, definitely. I think that probably many of those variants of unknown significance have been reclassified as a result of these ongoing efforts to be comprehensive in our understanding of, the mutational landscape of different diseases. I think too, some of these mutations may not seem like they're useful or actionable until they are.
Yeah,
Um,
right.
I'm thinking of one of the plenaries at ASH this year about, I believe it was SETD2 mutations that were that are more commonly found in a subset of patients of African ancestry and confer a poor prognosis and alter the immune microenvironment of this disease. And if you don't have the sequencing data there, you can't find these kinds of associations that may end up being actionable. I feel like more
Right.
information is always better, but that's,
Yeah, keep
us coming
sequencing,
from a
keep
place of
collecting.
luxury of having that.
True, true, true. Um, okay, well, I have to ask about one of our favorite episodes that you and I have talked extensively about, and that was the episode with Dr. Marcella Moss on CAR T for glioblastoma. Obviously, in doing that episode, it wasn't terribly optimistic. It's an aggressive, immunosuppressive, spatially complex disease. But I thought the episode was so good because, it didn't oversell. It was honest about early clinical realities, the challenges of antigen expression, and how different solid tumors are from the hematologic settings, right? Where CAR T has transformed care and is becoming mainstream in many ways. So,
I thought it was a great episode um and subsequently was really interesting seeing the paper put out by Steve Bagley et al. Of this, bivalent CAR in glioblastoma that, is one of the few reports that we have of a CAR having activity in solid tumors and having for some patients durable activity, with one patient having stable disease, I think for like 16 months or something, and GBM is just unheard of. I think
right.
that was like, a real 2025 has been a year where we've seen maybe some glimmers of hope in the CAR for solid malignancies kind of space. The other paper that I think reflects that is this report of a claudin targeted CAR
Hmm.
in
Yeah,
gastric and esophageal. I'd have to look back. That was a randomized trial, which
I know.
in a novel CAR, which is like, oh, they they're treating us just, like spoiled. And also, actually had a PFS and I think an OS benefit too. Really remarkable.
Yeah, I think, based on what you just said about that, the similar approach of glioblastoma and this, we really are turning the corner. Um, so I think great things are in store for solid tumor immunotherapy with this modality. Cost is always a big issue, and I think that's really now coming to the front line more than ever. I think to a certain extent you could have like the best ex vivo autologous T cell product, right in your hands, and really like scaling that out is a huge, huge. I think it's a bigger issue than ever. And also because of the in vivo manufactured T cells, I think we're seeing, a lot of that popping up. I've been trying to keep track. There are like 30 or 40 companies that have started. Half are like immuno-oncology, doing vector-based, in vivo manufacturing, and half are like LNPs or other modalities tackling things like, autoimmunity. So it will be interesting. I think we could really get there probably in leukemia and myeloma. Persistence is going to be the question. Only time will tell. Solid tumors, I think, will be more of an uphill battle with that sort of approach, but we'll
Yeah.
see.
I feel like there's definitely been a lot of, I don't want to say hype because that sounds negative. There's been a lot of interest in the ex vivo or I'm sorry, in the in vivo
Yeah.
CAR and also in allo CAR for some of the same um, kind of, I think in part trying to solve some of the manufacturing cost problem that you're highlighting.
Yeah, because it's as we know at scale, those sort of trade-offs matter. The manufacturing speed, the consistency. That's going to be a big question mark, right? With these in vivo products, persistence, immune rejection, if we're talking about vectors. So it's never easy. It's just different, I don't know, categories of hard. Is that fair to say?
Yeah.
We may have some angry viewers. um, so what else shall we touch on?
Yeah.
What do you think?
What other, did any, was there anything that our guests said to us this year that surprised you?
Well, I think if we had to name I don't know, I'm making this up, obviously, the grown-up theme of the year, it's this, that safety's not a vibe. It's now a discipline. I mean, we have a lot of labs here who are just exclusively focused on, safety of these immunotherapies. So it's really, really becoming subspecialized. And as you know, in our own lab, right, we sort of fell into it because it's just like the data's there and we have to, but it's never, I don't know about you, but it's never something that I set out to do, but it's so, so important. So I
Yeah.
think our second episode was with Dr. Bruce Levine. Um, and in the setting of CAR T cell therapy, I consider that a master class in that mindset, particularly around the FDA's warnings and or proposed warnings and the way we should think about risk, informed consent, and what are rare but serious, right? That's the key term. What
Yeah.
does that mean really in practice when you're practicing?
Which it's interesting too, the kind of that while the FDA put these black box warnings on for secondary malignancies, simultaneously this year they've relaxed some of the REMS requirements
Mm,
for administering CAR T. So we're kind of we've now become much more experienced and comfortable managing acute to subacute toxicities of CAR, and it's these like you said, rare long-term kinds of toxicities that we still are gaining more expertise in.
I think we have something coming out, I hope soon. I don't know when, but that will make it was a big splash at ASH, I think, by our own Julia Hahn Knoll. Oh, it is her last day in the lab today.
So sad.
I get so attached. She's incredible, but she gave a great talk, won an award at ASH about, some of these late onset toxicities, right? Well, and then since we're talking about safety, there was the episode 4 with, my dear friend Caroline Diorio, the feisty Canadian. I think she expanded for me, that safety lens into the real world of inflammatory toxicities. CRS, I've heard of, you're managing, right, these toxicities in real time, ICANS, but then the evolving concepts, and I think this is another buzzword for the year, or buzz term, whatever you want to call it, but IECHS, plus the genuinely, I think, discussed reality that manufacturing changes can affect toxicity rates. So I think, we've seen that a lot, and everybody does it a bit differently so that they could have their own secret sauce, so to speak. But I think this is going to lead to more I don't know, systematic investigation in those areas that were thought to be I don't know, so boilerplate. Does that make any
Right.
sense?
Absolutely. Yeah.
They're
Uh,
not.
yeah. Both on, some of the science I've seen this year and also some, data we've seen here at Penn internally. And, I really interested to see where the kind of manufacturing landscape moves and whether there is a demand for more transparency. Because that, these small manufacturing changes can really affect the potency of a product.
Yeah, yeah. Um, and some believe, like Caroline, I know, as we were talking about, that IECHS is a distinct biological process. It's not just like recrudescent CRS.
Yeah.
And my question was always, it's like, is this a new thing that's happening? Is it because we're going after? And it's just like, no, but now we're really appreciating that it's not this weird thing that comes up. It is probably a distinct biological process. Somebody asked me the other day, they're like, well, in relation to how we're modeling this, but what you're modeling is really on target off tumor toxicity. Um, so that's not really IECH. And I'm like, well, yeah, I mean it's different, but it's all in. So if we could quell the inflammation though, even if something's on target, I think that's something. But anyway, I don't know.
Yeah.
Models are, how does the saying go about models? None are right, some are occasionally used. I'm
Some are
messing
better than
that up.
others. Yeah. I don't know. Some are less wrong than others.
Yeah, there you go. We're on that scale. So what about the something I know very little about, but the ADC IO combinations, like the so-called Trojan horse therapies. So the I think that this year, my sense is that these antibody drug conjugates were, um, I don't know, they weren't framed increasingly, I'll say, weren't framed as just targeted chemo. I think that's how like we thought of them, at least how I thought of them. Uh, but I think they're really discussed now more as sort of immunogenic agents, right? That can reshape the tumor immune microenvironment, that can pair well now with checkpoint blockade. And clinically, as you know, I'm sure that 2025 had multiple high profile readouts and regulatory moves around like ADC combinations with immunotherapy. So,
Yeah.
um,
I think it's the same way that we have an ongoing better appreciation for old therapies, even like radiation and radiation's effect um, on the immunogenicity of a tumor. That as we use these other therapies too, we have, a more nuanced understanding of their mechanisms that are multifold.
yeah, yeah. And then I think we also touched on neoantigen vaccines and personalized mRNA cancer vaccines. Are we still believers? Of course, some people are, after the COVID mRNA era that we've sadly lived through, um, individualized cancer vaccination. And now I think the buzzword often is tumor informed. Um, Obviously, they remain a huge research focus. Although there are other investigators who tell me who used to do this, and this is all that they did in their research and clinical programs, like we've given up. You know, uh, we've given up on personalized vaccines in that space, and really what we're going to focus on are, driver mutations, and let's really target those with these different modalities. So the jury's still
Oh,
out.
one other great, really interesting paper I read this year looked at patients who had received SARS-CoV-2 mRNA vaccines with some proximity to when they received immune checkpoint inhibitors for their malignancies and showed like better survival of those patients,
Oh, I didn't see that. Cool.
which is really fascinating. And but again, the idea that stimulating the immune system with a vaccine that's not even necessarily trying to promote a specific anti-tumor response, but then helps boost whatever neoantigen specific T cells that you have that are being released from immunosuppression by immune checkpoint inhibitors. I think it's really fascinating. And it kind of is in line with what we've seen in some patients who get uh, get COVID vaccination and have had like spontaneous regression of some of their lymphoma. Again,
Oh,
we don't
wow. Yeah.
fully understand how the immune system and uh, is interacting with some of our therapies.
It's the old William Coley, right?
Yeah, yeah, yeah.
That's sort of,
Thank
there's a
you.
company, I don't know if I should say this, but in Canada, and basically they're still making, I don't know, this was years ago when I saw this, but they're big believers in that, and it happens. It's just predicting who will have that type of thing. And I think Coley, indeed, if you look through the history books, probably unfortunately killed as many patients as he cured, right, with Coley's toxins. But this company was branding it as Coley's fluid because the toxin part had this, very negative.
That name makes me a little uncomfortable. I don't really like that. That sounds a little gross.
Yeah, yeah. But there's something to it. I don't think, and I always say this, and I think you're a believer too. We're not engaging, whether we're using cell-based therapies or we're not engaging the endogenous immune system as much. And there's something to quote, Polly Metzinger, danger. We need danger signals to get the immune system going to really affect a meaningful sort of like response. Definitely something to it. Wow, we've covered a lot. Liquid biopsy guided immunotherapy. This was one of your interests at ASH that we've talked about, but what I got from you during our last episode, not to be terribly redundant, was that circulating tumor DNA kept moving from, I guess, what I would consider, and many others, a cool translational biomarker toward maybe more, I could be overstating this, a clinical decision tool, monitoring response. We talked extensively about anticipating relapse, so you should definitely check out episode 8 because I think you framed that very nicely, and potentially guiding escalation and de-escalation strategies, especially in settings, I think, to quote Janna, where imaging lags biology, or it was something like that you
Yeah.
said. So you're really excited to see how that's going to evolve, right?
I'm really excited to see how the circulating tumor DNA story plays out.
Yeah. Um, okay. What else should we talk about?
One
Well, I
other
think,
trial that I thought was really
yeah,
exciting this year, and I think is, a real first for the field, was the IL-18 armored CAR trial.
yeah. Oh, we did
Uh,
that.
I didn't do that, but uh, this is a CD19 directed CAR that constitutively secretes IL-18, and patients who had previously received CAR T cells, a substantial proportion of them had complete responses,
Yeah.
which is really remarkable. And to my knowledge, it's kind of the most convincing and strongest evidence that that these kind of souped up cars, or car plus kind of constructs, may really have clear clinical benefit.
What is the IL-18 doing? And I mean, I worked on this except for years. And I don't know. We shouldn't admit this, but really, what is it doing? Is it boosting the T cells? Is it bringing in, I don't know, uh, other cells like NK cells, like into the tumor?
Yeah.
Um,
And
and
why
why
wasn't no, you go.
why isn't it toxic?
That's
Why
exactly
isn't
what
it
I was going to
horribly toxic?
say.
And we don't have a good answer.
I mean, and I think the folks that use it in ALL do see more toxicity, but in lymphoma, my understanding was that it seemed comparable to the regular old CD19 CAR. So I think that's a really exciting possibility, and I hope we're able to offer that to our patients in the future.
Yeah, no, absolutely. So, what do you think about increasing safety in that space? I mean, there are a lot of elegant logic gates and things out there, and the preclinical papers are just, beautiful. I love to read them, but
But
how
it's
well
really easy to cure cancer in a mouse.
yeah, a lot of happy mice. But I wonder, but if you're saying like an indication like at ALL, where maybe there's like more toxicity if you have constitutive expression of like one of these cytokines, um, a logic gate maybe is logical.
Right, or some, tunable car or yeah, some having additional controls uh might be helpful. I think we're still in the era of, you know, the CD19 car era where
Yeah,
we've kind of been using the same hammer on all these different size nails. Um,
yeah,
and,
yeah.
and there's definitely going to be room for more precision and tuning.
But maybe you just have to use the right cytokine, like our friend Anusha Kobasi, right? IL-9 is just incredible. I mean, we'll see how this bears out in early phase safety trials, but IL-9, it seems to be like, especially to use this orthogonal system, like, right, this orthogonal cytokine signal that boosts T cell function
Right. And
with
again, having that control or
yeah,
that tunability
yeah, exactly.
for both potency and for safety reasons.
Exactly. So, and again, I'm a big believer. There have been a lot of efforts, but I think that group will probably get to it. How can we really enhance CAR T without relying on traditional lymphodepletion? And I think we will be able to get there with the right armor and the right tuning.
Yeah.
Great. Well, I believe we've covered a lot of ground, unless there's anything that you feel that um, we've missed. There are tons of things I'm sure that we've missed, but uh, we have just a short time. So we
I
have
think
the luxury of
2025 has
picking our
been
favorite.
2025
Huh?
has been an exciting year for cell and gene therapy, and I'm looking forward to seeing what 2026 brings.
Yeah, I think our theme, our takeaway is, make it work, make it safe, make it make sense. And so that, I guess, is your summary you were ready for me this time of ImmunoLogic 2025. I guess my version, you're going to laugh at me, but the immune system and the T cell, still the hero, still the wild card, and we're going to get better at being responsible directors of the story or responsible drivers if we're talking about CAR T cells, of these chaotic improvisers. Um, so great. So to everybody who's listening, thank you for spending this year with us. We were renewed for a second season, I heard. Let's see how we do. But whether you've been here since episode 1 or you're just finding or coming across ImmunoLogic now, um, if you have great topics that you want us to tackle in 2026, so bigger debates, I promise debates and sort of like the prequel. I don't think we got into debates, but that's something we should definitely do. Deeper mechanisms, probably not, but there's an audience for that. Clinical dilemmas, manufacturing realities, send them our way, because the best part of doing this show is that we get to build the agenda with the community that's actually doing the work. And what really resonates with me, Janna, when we were talking about, what's the show going to be about? How are we going to differentiate ourselves from? There is some competition out there. There are a few other immunology, cancer, immunotherapy podcasts. You said to me, I want this to be a show where you get just raw, new insight. It's not something that you're just reading. Like, I don't want to tune into this podcast and hear something that, I've read already. It's really the perspective and pushing it.
Yeah.
So until
Well, I've
next
really
time. Oh,
enjoyed
go ahead.
hearing your perspective and our guest's perspective, and I'm excited for some more episodes to come.
Yes, we will be bigger and better than ever.
Yeah.
Okay, so until next time, be well, stay immunological, and we'll catch you on the next episode of ImmunoLogic Season 2. Thank you.